you very much for attending this workshop today on reinventing workforce rostering in NHS trusts. So the purpose of today's session is really to look at rostering in the NHS, and particularly the Rotageek technology of how that can reinvent the way that we can do that, and focus specifically on one trust, which is Ashford and St Peter, where Debbie and Colleen will kindly show us a case study of how they've recently implemented the solution. And they'll go through why they felt this was the right solution and what business need it was meeting. I think at a more general point is that, many studies now show that an engaged workforce is key to an innovative workforce. And clearly, with the health system being so people dependent, looking after the medical and administrative professionals who work in the system is critical to getting an organisation which is going to be able to rise to the challenges of the backlogs caused by COVID. And if we don't have engaged professionals, then getting those changes through will be more difficult. So we believe that more effective employee-centric rostering, which recognises the needs of the patients, the trust, and most importantly, the employees within those trusts, is an important way to go forward. So that's really what we're talking about today. And we're going to cover the challenges NHS trusts face in managing their workforce alignment using manual or outdated systems, give you a sort of sense of what a future fit, people first, collaborative rostering tool can achieve, and then specifically to talk about the lessons learned by Ashford and St Peter. So the way we'll run the seminar today is we've got a panel who I'll introduce you to in a minute, who will talk through their own individual experiences of rostering. But before we do that, we've got a little poll that we'd like to launch online, which should come up on your screens now, hopefully. And as you can see, we'd just like you to very quickly answer these three questions. So, do you have an e-rostering platform in use at the trust today? And there's three options there. Yes, and it's great. Yes, but we don't really use it. And no, we're still doing it manually. So secondly, what's the biggest challenges with current rostering systems that you know? And there's 5 options there. And finally, do you know your current e-rostering's attainment level at the trust? All the answers are anonymous. So if you could all just give that a minute, please. And if you wouldn't mind, just clicking in those boxes as you understand the position in your own trust. So if you could look at those now, and we'll just give that a minute, and when you've done it, hit submit, please. Okay, and if you could close the poll, please, now. So if we just have a very quick look at that, so everybody, 50% of you've got one and you're feeling it's going fine. The other 50% are either manual or still got work to do. The biggest issue there coming across is lack of integration into different modules or products, and interestingly, a lack of a cloud-based solution. If we nip down to the third question, the biggest response there we're seeing is issues around timetabling. So it's just interesting to see that that's about half of you are relatively happy with the system you've got, and half of you are looking to improve them. So that's an interesting context to the discussion. So broadly, the way we'll run things today then is very much a Q&A structure, and we'd like you to ask questions as well. Whilst there'll be formal questions at the end, if anybody of you just want to raise questions on the chat function on Zoom as we go through, just please type them in and I'll make sure that we put them through to the panelists. So without, from there then, if we just go on and introduce everybody to the panel today. My name's Adrian King. I've been a management consultant for 30 years. And my interest in this is I've written quite extensively with the Work Foundation on creating employee-centric, flexible labour solutions. And I also lecture in health innovation at Imperial College. If we go round to the rest of the panel, Ahmed, if you'd like to introduce yourself, please.
Thanks, Adrian. Hi, good morning, everyone. My name's Ahmed Shahrabani. I'm co-founder of a company called Locum's Nest, and I'm an acute medicine SHO, still practicing. But thanks for having us, guys. And I'll hand over to Roger.
Roger, you're on mute at the moment.
There was one. Hi, I'm Roger Wilson. I'm an HR and OD consultant working across a range of sectors, including the NHS. I've got over 30 years direct NHS experience, 13 of them as a director, but I've worked across all NHS sectors at all organisation levels. So my interest in this is clear in terms of, you know, how do we get the best use out of the resource that we have available to us, really. So I'll pass you on to Colleen.
Hi, good morning. My name is Colleen Sherlock. I'm Assistant Director of Human Resources at Ashford and St Peter's Foundation Trust. My role is I'm the Trust Lead for recruitment, temporary staffing and workforce information systems, including rostering. And my background is HR in the NHS in various roles and trusts. I'll hand over to Debbie.
Hello, good morning. My name's Debbie Beck. I'm the Workforce Deployment Systems Project Manager at Ashford and St Peter's Hospital, which means I'm responsible for helping the Trust to implement the workforce systems, including a recruitment system and rostering. I've got 10 years experience in the NHS. I used to work in medical workforce and at HEE, and now I'm a project manager at Ashford and St Peter's.
Okay. Thank you, everybody. Roger, perhaps you could just kick off the discussion, please, by sort of setting the scene. And from an HR perspective, why do you think that rostering is at the heart of the NHS workforce plan? And how do you think that's going to develop over the next 5 to 10 years?
Yeah, thanks, Adrian. I mean, it's several fold, really, the answer to that question. I think at the core and at the heart of anything to do with workforce development or focus of any HR director will be improving patient care and improving patient safety and making sure that the quality of care we give is at the right standard. In order to do that, you need a suitably qualified, developed and engaged workforce as well. And I think if anything, over the last 15 months, what our experiences have taught us is that you know, it's been so hard on people, and actually there's such a major risk around NHS workforce at the moment, around future supply and future engagement, that, you know, we need every tool in our armory, really, to make sure that we're making sure we're deploying our workforce in the right place at the right time with the right skills, and that they're safe, and that we're looking after them as much as we can. And wherever we can, we're giving people as much control over their working lives as we can, really. So that's been hugely important over the last 15 months, but it's going to be, you know, really, really telling over the next 12 months too. So I think rostering, using great technology, is really going to help us plan our services and our workforce to help them plan their lives and maintain engagement over the next 3 to 5 years, really. So it's about good technology supporting the workforce and supporting clinical delivery.
Yeah, and do you feel, Roger, that the trusts who have more effective rostering solutions and ones which are more employee-centred will have less of a challenge in recruitment as labour markets become tighter?
Yeah, I mean, I'd say less in terms of recruitment, but also less in terms of retention as well, because that's one of my big focus as an HR director was I knew how much work we were putting into recruitment and campaigns around recruitment. What I felt we needed to do more of was about campaigns around retention, and making sure that we were retaining the skilled workforce that we have and keeping them safe, keeping them engaged, and keeping them involved. So that, I think, engagement's core. The evidence base is out there. Everyone is clear about the need to have an engaged workforce, and rostering and giving people access to good technology in the workplace. All of us are used to it in our domestic settings. So, and we somehow neglect that really when people step over the threshold and come into the workplace. So I think that really is going to be a increasingly key factor over the next couple of years.
And do you think that rostering is a key part of the sort of employment deal really in terms of getting positive engagement?
Yeah, it's been, well, it's a master of understatement to say it's been a strange 15 months, but clearly, my engagement with the NHS over the last 15 months is things have not really changed really for people working within the NHS. In fact, it's just got more intense. And whilst the rest of the population have been able to sort of have more choice in the way that where they work and how they work, and that has been a positive really for a lot of people over the last 15 months. It hasn't happened for a lot of NHS people. It certainly hasn't happened for frontline NHS people. So it's about, everyone is now more acute about work-life balance and about making sure that they have the right balance, and also there's a safe balance between work and downtime. So rostering and being clear around that, it ensures fairness, equity, and safety. So it's critical.
Thanks, Roger. Perhaps if we go to Ahmed a minute, as you're a doctor yourself, what's been your experiences, sort of good and bad, of rostering, and how does it impact the way you look upon engagement?
Yeah, no, thank you. I mean, I remember it very, very well. For a number of rotations I've worked, the typical status quo is the trust has an e-roster, should they have an e-roster, and what happened with us was the e-roster would get converted to an Excel spreadsheet, which would then get colored in a different way to make it easy to follow. That Excel spreadsheet will then get printed out and be stuck up on our clinic room, and then we as doctors would, amongst us, note down with a pen what we were free to do, what we weren't, and there were squiggles on top of squiggles and edits, and then that piece of paper would then get re-inputted on the Excel spreadsheet, which would then get reflected on the e-roster. And that process was ludicrous. I mean, yes, there was an electronic roster, but it was just there for the sake of it, just to tick boxes. It didn't add any value to us as clinicians, and I'm sure it wasn't user-friendly for the trust that had implemented it, because there were kind of a backlog of 2 or 3 other processes that needed to happen. For us, for doctors, fundamentally, we just want something that works for doctors. Doctors work very differently to other healthcare group workers, and vice versa. So it's something that's built for the end user rather than something that's forced upon them, is what we resonated very, very well with. And it's nice to see that that's changing. I mean, I still pick up lots and lots of weekend shifts, and rostering today is very, very different to what it was, 4 or 5 years ago when I did my foundation training.
Yeah, thanks, Ahmed. And if we move on to Colleen now, perhaps you could just give us an overview of what you're trying to achieve at Ashford with using the Rotageek solution. And we've got one specific question just come in from Tom here, who was asking, have you used Rotageek for medics only or for all staff? And if it is principally for medics, what's the sort of balance between junior and seniors in the way that you're using that? So perhaps if you could just give us an overview first before just commenting on Tom's question.
Yeah, so I think, thank you very much. I think we're going to pick that up. It's a great question, and I think we'll cover some of it as we go through our slides, actually. And what we don't, then we'll try and incorporate as well. So if we could have our slides, that'd be marvellous, from the first one. Thank you very much. So first of all, just wanted to give you an idea of which organisation Debbie and I belong to. So we're Ashford and St Peter's Hospitals Foundation Trust. And we are an acute provider of healthcare services. We are in the southeast of England, if anyone hasn't heard of us. Not the Ashford, not the more famous Ashford in Kent, but we're Ashford near Heathrow, and St Peters is sort of next to the M3, M25. And we are outside the M25. We actually fall into Surrey. In particular, where northwest Surrey is the area we belong to. And that's always a challenge for us in terms of attracting staff and competing against the attraction of living in London, as well as London salaries for substantive or for bank staff. And like any NHS organisation, there's challenges wherever we're located. And those are ours in particular, is the sort of closeness to London, but not being in London. In terms of our size, we've got about 4,500 staff. I think might be more than is on there at the moment. And doctors, in answer to the question, we have around 500 doctors. Things about 280 of them are juniors, and the rest consultants and middle and senior grades. If we could just go on to the next slide, please. So our challenge and what we wanted to sort of share is what wasn't working for us really about the current rostering system that we had is so our approach is to look at this in sort of three levels. One is what the organisation needs, one is what individual teams, departments, managers need, and then the third is what individual employees, colleagues need. And that sort of picks up on what Roger mentioned as well about needing to support and provide flexible support for staff as well as much as possible. So this was our picture when we started our current rostering arrangements, just a bit of a mishmash of what we had. So for our nursing and midwifery, we've got a rostering system that includes bank and agency staff. For our doctors, it's very much as Ahmed described. There are spreadsheets and different systems. We've got a job planning system, an exception reporting system, an appraisal system, and a lot of spreadsheets, and none of them talk to each other. And it's a similar sort of picture for our allied health professions and other clinical staff too. So in terms of that support for an organisation, no, very little visibility across the trust of staffing levels, our fill rates, leave requests, anything like that, apart from our nursing and midwifery. Very difficult to have an overview of what's going on, and not easy for staff to understand, where and when they're supposed to be working, or in order to give staff the opportunity to plan ahead. Rotas are done such short term, just a few weeks ahead. It's really difficult to plan big life events or or significant things that you want to happen. Next slide, please. So the other thing that we were very much mindful of is we had developed a workforce transformation strategy with 8 strands really, and if you can see them on the slide, that they're on there. Then we reviewed that against the National NHS People Plan that has been published, and we've slightly aligned our own transformation plan to align to the People Plan. But it was very much the same things that we were picking up on, that are issues for all of us nationally. And our workforce deployment systems project actually sits very much under our flexible working work stream of our plan, because that's where we see it having the biggest impact, is if we can give that flexible working, that support, that empowerment to our staff, then it will solve some of those retention problems. It will make us an attractive employer, and it'll make it easier for managers and for the organisation to see what's going on. So we also think it picks up in some of the other work streams, of course, around efficiency and support and reducing agency. But yeah, so the key thing is that one. So I'm going to just hand over to Debbie to just talk about some of the other issues that we've, how we've approached our project. Before I do, sorry, just in answer to the question where we are at the moment, we are rolling out, so the new system that we're rolling out, which is a rostering and bank and agency system, is 2 different suppliers, but integrated systems. And that was part of what we wanted in order to give us our flexibility. So with the current systems, we don't, it's a great roster system that we have, but we don't see that organisational level, that visibility, and it's not as empowering for our staff as we wanted. So we very much took on NHS improvements guidance, I think from the end of 2018, which was around, it's our data, it's our systems, we want to get to one source of the truth. So let's get suppliers in that can help us to get what we want, rather than be restricted with what the systems do. So we have and are rolling out interoperable integrated systems, and it's not just for doctors, it will be for all staff. Our first phase is for clinical staff, and then we hope to move on to non-clinical staff too, when we've got all the clinical departments sorted. So I'm going to hand over to Debbie now. Next slide as well, please. Travis.
Thanks, Colleen. So the Trust started talking about what they wanted with regards to a group of systems or a system for rostering in late 2018, and sort of actively began working on the project towards the end of 2019, with the team sort of engaging with NHSI and their supplier reference group, as well as internal stakeholders. And we were able to identify our vision for rostering, and part of this is being able to create rosters according to the demand of our patients, and also working to match this to the supply of team members in the different staff groups. We're trying, the sort of caption of our project is improving workforce systems for team ASPH, and we're trying to sort of support managers and empower individuals to give them a real flexible program really to their rostering. If you could go to the next slide, please. So we've got 4 main objectives with the project, and from our rostering platform, we decided that we needed to have an agile and flexible system which would work for all of the staff groups. This would help to give visibility across the Trust at different levels, maybe divisional or departmental, or even across the whole organisation. And we needed a system or group of systems which would work together and allow us to roster our organisation together. We wanted something that would allow us to change our needs as well, and also future-proof our rostering, because what works now may not work in 5 to 1 year's time. So we really wanted a system that would sort of listen to us and take that into account. Another thing that was really important for us is access, employees' access, and what we have started to call a single source of truth. So via a mobile app that's always kind of real time, what those people are due to be doing in the roster and who's going to be working with them, and who's there to support them as well. Another thing that's really important to us is to have responsive reporting at all levels. So if the Chief Executive wants to know who's in the Trust at any one time, we wanted a system that would be able to show her that. The same for the service managers. If they want to see who's in their department and where they are, we wanted something that would be able to show them that at a glance. In order to make sure that what we wanted was actually available and in the market, we decided to run a 6-month pilot. We did this by releasing an expression of interest last year, which was sent out to the supplier reference group the NHSI were working with. And I think we received around 18 responses, some of whom met all of our requirements, some of whom only met 1 or 2 of them. But we started running the pilot in the middle of last year, which went a little bit more slowly than we would have liked, but for obvious reasons. But it really helped us to build a technical specification of our final system and what we wanted from that system. So that was really helpful. And you can see that we're kind of branding our rostering and recruitment projects within the Trust as connecting people to support the teams and empowering you, which is our team ASPH. Thank you. That's
yeah. Thank you, Deb. Thank you very much. So look, just before we move on a little bit, and whilst we've got Colleen and Debbie in the hot seat, are there any other questions you might like to just pop in over the chat, which are direct to the case study that you've just been presented? So I'll just give that 30 seconds or so and see if there's some specific questions popping up. 10, 9, 8, 7. I think we can move on. Nothing's come through at this point. So I think that was really interesting to see how you're doing that. Within one trust. I think one issue which would be interested, and perhaps Ahmed could lead on this, would be how do you see this working with bank staff and part-time staff? Because clearly that's a very big part of the way that the NHS is resourced these days. So Ahmed, could you comment on that first, and then we could maybe open it to the group?
Yeah, no, of course, happy to, Adrian, thanks. So, I mean, with me, I completed my foundation training in 2016, I think it was. And the year I left, I think 55% of my colleagues across the NHS also left full-time training to do F3s, F4s, go to Australasia, go into other professions, etc. And that trend has continued. So where I'm getting to is there are a lot of people who value flexible work today, much more so than before. At least it's much more normalized now, and people respect and value it. So, you know, with bank staff, it's two areas here. One is to make sure that the roster appreciates and respects, you know, less than full-time trainees and allows for flexible rostering so that, you know, they feel embedded and part of the family of the trust. And the other is for bank staff really to be embedded. I mean, with me personally, I work weekends on the hospital wards at Ashford and St. Peter's and other trusts within the collaborative they're part of. And I have a lot of respect for that because I feel valued at the trust as a doctor. I don't just feel like I'm there to provide a service. I get along with the consultants, the nursing staff, the AHPs, and fellow juniors alike. And I think that's where we're heading to now as, you know, as the NHS. It's valuing flexible workers as much as we do permanent staff and making us feel like part of the community. We're there at the teaching sessions, we're there in the mess, we have all the benefits that full-time workers have as much as we can. And it's part of that feeling of being part of the family, and that's what will drive kind of job satisfaction and kind of the feeling of autonomy and power and control, and will ultimately lead to better patient care, to be frank.
Right. And I think, Roger, if you could comment on that more from an HR perspective. So I think the way Ahmed described that was, yeah, there used to be a sort of core periphery model, and the bank was a periphery. It came in to meet a short-term problem, and now there's a view of trying to make that banked part of it not a periphery to the organisation, but a flexible part of the core. So how would you see that developing going forward?
Yeah, I mean, I think, again, my perspective on this is that there's been traditionally, we've been good or better at developing banks, certainly for nursing staff. So they've been the priority, and most organizations would say they had a relatively well-established nursing bank. And I think certainly the reliance on locums that we had was no longer, you could never really feel that level of sort of confidence around who was going to come through the door, if they were going to come through the door, and where they were coming from, and how much rest and recuperation they'd had, really. So all of those things were kind of, and also there was the huge elements of the cost in terms of, so with that, was there a sustainable service? So I think what we've had to do is we've had to think very carefully around how we broaden, picking up on what Ahmed said, completely agree with him in terms of people's perspectives on work are changing, and we have to be reflective of that. But we also have to sort of recognize that the multidisciplinary team element of that peripheral workforce is going to become increasingly important, because where you can't get a doctor, you might get a nurse with an enhanced role. It's all about skill mix. How can you bring AHPs in? So it's about utilizing what resources you have available to you, and not just blindly following a certain model that you may have, you may have used in the past. Because if you can't recruit people, then you're going to have to think again. And I think on the elements of, I think the other thing that we've done as an NHS in the past is we've kind of it has been very much focused on central control, and we've done kind of rostering to people. And this is about, I think we've also got to start sort of just switching that dynamic a little bit and say, how can we work collaboratively to roster?
Yeah.
And so that they're key partners in that. And so I think engagement's at the core of it, isn't it, of everything we do, whether you're a substantive employee who works, a notional full-time contract within the NHS, or you're somebody who wants to give hours and an input to, and we've got to just think differently and more progressively around that, and seeing the workforce differently. And I'll shut up at that point.
Yeah, I thought that was a really interesting point, Roger, and maybe it's something that Debbie or Colleen could comment on, is that you're seeing this as a shift from rostering done to people to rostering done with people. So Debbie, Colleen, and I was very conscious when you made reference to the mobile aspect of the technology solution, that people could see who they're working with that day. What sort of feedback have you had from people? Are they giving you this sense that they're no longer being rostered, but they're engaging in the process of rostering with the organisation?
I'll go first and let Debbie talk about that bit in particular. I think what that resonated completely when Roger said that about not wanting to have rostering done to people. I think we also in this project, perhaps we didn't draw out as well, that we are taking a very multidisciplinary team approach to this, so that the service we provide to our patients is not just rostering doctors here, rostering nurses here, rostering the therapists here, but actually it's a whole team that provides that service. And we are really advocating development of new roles to improve patient care and also to solve recruitment shortages. So we've even got one of our wards where our nurses and therapists are on the same roster and work aligned together, which is really exciting to see. And that's sort of the approach that we've taken, that it's not just about seeing which other doctors or which other nurses are on with you, but which of the whole team are on with you and who's available to provide that support. And I think the other thing for me that was a sort of driver in doing this, and it relates to the bank work, is we've been looking for solutions that would reduce our need to rely on agency. So part of enabling people to work bank is making it as easy as possible for them to pick up bank shifts in whichever trust they want to. And the traditional approach was, if you want to be on a trust bank, you register with that bank and you're on their payroll, and then you do all their employment checks and their mandatory training. Then you go to another trust and you join their bank and register and do it all again for every single trust you want to. That's a doddle with an agency. You just sign up with an agency, and then the agency can deploy you to any trust on their banks or any organisation on their books. So what we did with the help of Ahmed's team a few years ago was to create a collaborative bank approach across our neighbouring trusts, so that you could register with. It started with doctors. You could register with one trust and then pick up shifts in any of the other trusts. And that for us is really key to enabling and empowering bank workers to have that choice of which shifts they want to work, where they want to work, but as simple as possible. So it's as easy as possible for them. Yeah. Debbie, you might want to talk about the feedback. We have been talking to people a lot about understanding what they want and what they need. That's why we did this as a pilot rather than a big bang approach, so that we could develop the systems. And it's been brilliant to have the opportunity to actually develop systems rather than just this is the system, this is the way it works, but to keep developing it in partnership with the suppliers. And it's been great doing it as a pilot so we could keep developing. Debbie can feedback on what staff have said.
Yeah, so what we found to start with was that people were very much attached to their spreadsheets. They really didn't want to move away from them. We also found that the consultants view rostering in a very different way. So they have their job plan. They know on a Monday they're here, on a Tuesday they're here, on a Thursday they're here. So they don't really need the rostering system to tell them where they are. What they need the rostering system is to tell them where their colleagues are if they need support in theatre, or if they've got a difficult case, who they can call on to come and operate with them potentially, or which juniors are supposed to be with them in the theatre or on the ward with them. So that's something that we've worked really closely with the team to kind of get that the use case for the consultants correct, really. Another thing that we also found is with the community teams. So we have quite a few community teams, and they may not be part of the same team or even the same staff group, but they're in the same location. So if they need help with somebody because there's been an emergency or something like that, they can actually go onto their app with a few short clicks and find out who else should be in the building with them. So we've sort of found that that's the AHPs and the a lot of the community-based teams have found that a really useful functionality that I think they're quite looking forward to having, because when it was on a spreadsheet, they just saw the people who were on their spreadsheet. Whereas now, because they can be linked via locations and I suppose community bases, they can actually see who else from other rotas and other spreadsheets are going to be there with them. So we're trying to show people that their spreadsheet is still there, it's just more interactive, and it's, like I said, a single source of truth, and it's real time as well. So if there's been changes, those changes are reflected in the app for them sort of almost immediately as well, which I think will be really beneficial.
Yeah, thanks, Debbie. I mean, I'm picking up some things from this conversation, which is around, this is a technology tool which is sort of increasing engagement, building involvement, and more importantly, sort of facilitating the development of sort of flexible multidisciplinary clinical teams, which all seems to be shifting very much to the things that Ahmed said earlier, that there's a younger generation of people coming into the NHS as the workforce who are not necessarily looking for a 70-hour-a-week full-time commitment to one trust and wish to do other things around it, but are no less committed to the NHS in the time that they're spending with inside the organisation. So I think it's really interesting. I'm just slightly conscious on time. So this is again back to Colleen and Debbie. So there's one question just come in from the audience, which is going, what did you find most difficult about gaining support internally to make change with your rostering system? And how did you overcome those sort of barriers to change? And then, yeah, as an extension of that, which is, if you were going to start your pilot now, is there anything that you might do differently which would help some of your colleagues if they're planning to go down the same journey?
Do you want to go first, Debbie?
Yeah, sure. So I would say probably with regards to gaining support internally, we have had a little bit of pushback from some staff groups. So as I said, the consultants kind of said, well, why do we need this? Because we know where we're supposed to be. But actually we said to them, well, that's fine, but what else do you use your current process for? And when we discovered what that was, and we said, well, actually we can help you to see that by just going into the app in a few short clicks, rather than searching through your emails for the most recent email from the service manager, which shows you the most up-to-date spreadsheet that was changed yesterday or 2 hours ago or what have you. They kind of really, I think, sort of grabbing onto it a little bit more and saying, actually, this is better than doing all of that searching and looking at those things as well. Probably another thing that I would, if I was going to say, what would we do if we were going to start now rather than this time last year or before this time last year, I'd probably say don't underestimate the amount of time that it will take. Make sure you implement the cycle of change as soon as possible. That was something that we perhaps did a little bit late due to the lockdown sort of earlier at the beginning of this year. Lots of people didn't have time to engage in the change process as soon as we would have liked. So I'd certainly say that that's something that you should be mindful of.
Thanks.
Yeah,
Give yourself lots of time.
Yeah, I just add as well. I mean, of course, yeah, we were hoping to start rolling out this project just when we went into a pandemic, so that time wasn't great. I think we spent a lot of time talking to, especially people at all levels of the organisation, about what they wanted, and that's what helped us to shape our sort of 4 clear objectives, which were not just around the rostering system, but that empowering the staff, having that overview, being able to support annualised job plans for consultants, multidisciplinary approach, and supporting new ways of working. So there's quite a few things that came out, and we've kept them at the forefront of this is what we want to achieve. I think the other thing, when we rolled out the pilot, we just sort of thought, well, it's just a pilot, we're just testing. And now we've come to roll out the full implementation. We're very mindful of the need that it's a big change programme. We've got to do lots of communication, get people on board, and we're really focusing on getting enthusiasm from staff at the ground level, so they want it. They don't feel it's been done. The project isn't been done to them. That they want, they want this thing rolled out. And we didn't do so much of that in the pilot because we just felt, well, it's just a pilot, we're just testing with them. So we certainly experienced more resistance and negativity from staff through that pilot because we just underestimated the need, recognising it was a change programme in itself, and we really needed to communicate more with what's happening. We just thought, oh, they'll just test it, and we should have approached it just as much itself as a change programme and done that engagement as well. Okay. Because now we are with the wider rollout, it's it's easier.
Thanks very much. Look, again, just with an eye on the clock, are there any other questions that people from the wider audience might like to bring in? And if you would, could you type them in the chat function now, please? And just to say here, if in 5 minutes time some questions spring to your mind that haven't occurred now, if you answer any email that you've received from Rotageek, just type the question in, and Travis will get back to you from any of our experts with an answer for that issue. So at the moment, nothing else has come in. So I think that leaves me to sort of just say thank you to all of you for attending today and for sharing some of your time to, yes, we have one here. We've got one just come in, and this is from Tom. Could you let me know how many of the 500 are not e-rostering? Appreciate that the last year hasn't been standard, but how much resource is allocated?
Of our medics, I don't know, Debbie. I mean, we are in rollout. We're not fully rolled out yet. So we've rolled out to 3 of our divisions, and we're probably about halfway through. But they will all be e-rostering when we get there.
Right, thanks.
Yeah.
So look.
And there was another question as well to all panelists about, has the current journey with Rotageek made it easier to open up conversations about innovating in other areas of HR and workforce planning? Yes, definitely. That idea of having a more flexible approach around rostering is definitely opening people's eyes, I think, to having a more flexible approach to lots of things. I think it's not the only issue though. I think it's one of the things coming out of the pandemic has it's just been made things easier to innovate and to create new solutions. And I think we've also come to a place where we've all been fighting hard against our shortages in certain staff groups, and trying to persuade, certainly from my point of view in HR, trying to persuade sort of senior managers that we could look at different roles, things like nurse associates, growing our own staff, bringing people in different roles and developing them. And I think that conversation is a lot easier to have now as people are just understanding that that's a different approach. And bringing community people in to help us during the pandemic in sort of non-registered roles has just been such a brilliant experience that I think that is really helping to make people more open to that concept.
Yeah,
so a number of things.
Yeah, thank you, Colleen. So look, with the eye on the fact that we were finishing now, thank you very much to everybody that's come to listen to this story of Ashford and St Peters. If you do have any questions you want to follow up, please get in touch with Travis. There will be a recording available of this seminar if anybody wants to pursue it and listen to it at their leisure. And finally, thank you very much to Roger, Ahmed, Colleen and Debbie for giving us a really interesting insight into that. And just one old consulting story to finish the seminar. Years ago, I was involved in implementing a balanced scorecard in a very large organisation, employed 10,000 people. It was very people-centred. And the balanced scorecard had got 4 elements in. One was on employees, one on quality, one on profitability, one on operational excellence. And after we'd run it for a year, we found if your employee engagement metric fell in Q1, everything else fell in Q3 without fail. So employee engagement became the leading metric on how we manage change in the organisation. And I think any tool, particularly within the context of the challenges the NHS are clearly going to face in the next 3 years, and a younger generation of workers who want a more involved, empowered, engaged, flexible working life, a tool which creates rostering as an involved process between the employee and the trust is far better, to use Roger's phrase earlier on, having a system which rostering is done through 2 people. So with that thought, if we now have technology that can help employee engagement and bring a workforce aligned to the objectives of a trust, then that seems a very good deployment of technology. So I'll leave that little thought with you and say thank you to everybody for attending today, and we look forward to talking to you in the future about this. Thank you very much.